amount of time, we'll be moving on to the last speaker, Dr. Raveendra sir. He will be talking on how to solve acute angle closure crisis, the ultimate deadlock.
Thank you. I'll try to quickly move on through the slides. So the history questions related to angle closure glaucoma are the number of days the symptoms are there, whether the age is more than 50 years, then what are the other risk factors, and then in the anterior chamber we have to see the inflammation, the conjunctiva, we have to see the circumcorneal congestion, corneal edema, we have to see IOP, we have to check, and then we have to look for the iris and the lenticular changes and pupils, whether they are mid dilated, and of course vision is most important. And then these are all the medications that we have to keep in mind, which are the medicines to be used, is to be kept in mind, is to be contemplated. The classical flow chart comes, the initial treatment. Okay. The initial treatment. So initially we have to decide what is to be the what is the diagnosis, whether it is classical angle closure glaucoma or whether it is one of the differential diagnoses. And then the initiation of the treatment is important. We have to give the pilocarpine, oral glycerol or Diamox, and then whether the pilocarpine is to be given in what frequency, means initially whether to give it in quick succession or whether to wait for IOP to be reduced is an important decision, because over 40 IOP, the pilocarpine itself may be harmful. And then once we come to the differential diagnosis, we have to be sure whether it is primary angle closure glaucoma or anterior segment uveitis and cluster or migraine headache or conjunctivitis or giant cell arteritis, glaucomatous cyclotic crisis or IC syndrome or keratitis or neovascular glaucoma, and then whether any of these drugs are the reason for the angle closure glaucoma, it is also important. Whenever it is bilateral angle closure glaucoma, we have to be very careful that we diagnose the exact cause and withdrawal of the treatment that the patient is having, and the precipitating cause may be the main mode of treatment. And if it is uveitis, we have to give the steroids. If it is lens-induced glaucoma, we have to go for the lens extraction. Whatever it is, whenever it is angle closure glaucoma, early intervention is the key, and triaging of the patient upon reaching the hospital is one of the most important things. Otherwise, the long-term effects upon the neuroretinal rim and angle and nerve fiber layer will be apparent. And one of the most important things is gonioscopy, so that we do not miss the prevention aspect of the acute angle closure glaucomas. And after the PI has been done, it is important to identify plateau iris so that we identify the reasons and treat in the correct modality. And if it is not the primary angle closure glaucoma and silicone oil glaucoma, we could be in for unpleasant situations, and therefore appropriate treatment, laser medical treatment will be required. And if the trabeculectomy is risky because of in uncontrolled IOP, we may have to do IV mannitol, and then still IOP may be not lowering, and then cyclophotocoagulation has got a place there. And so laser iridoplasty was also discussed, and compared to PI, it is not so efficient, and for the termination of the acute attack, it is somewhat useful. And so I have been able to quickly move ahead and give the hall to the next speakers. Thank you.